Morning, Madam Chair.
Good morning.
Nice to see all these familiar faces from the other chamber in your room today.
We're excited.
I'm Mike O'Neill, representing the Association of Dental Support Organizations, requesting introduction of 25 RS 0199, updating the Dental Practice Act. For those of you that were here last year on the committee, this is Senate Bill 103 without any changes. That bill moved out of committee last year, but didn't have time to work it on the Senate floor.
Thank you, committee. Do we have any objections to making this a committee bill? Seeing none, thank you.
Thank you.
Any other bill introductions this morning? Yes. Senator Murphy.
Got you, didn't it?
Yeah, just for a second.
Thank you, Madam Chair. I have 25 RS 0218. It's an act concerning public health relating to infectious or contagious diseases. And 25 RS 0217, an act concerning public health concerning the conscientious right to refuse.
And do you, would you like these bills to be committee bills?
Yes, please.
All right. Any objections to these being committee bills, committee? Seeing none, thank you. These have been introduced. Any other bill introductions today? Seeing none, we will jump right into our agenda. So pleased that we will be having an update from the Kansas KDADS, or Kansas Department of Aging and Disability Services. And I just want to state from the outset, when I've testified many times for years all over the country in various states in Washington, D.C., but when I became a senator, I thought, okay, this is a different world sitting in this chair. And I remember saying to Secretary Howard, now, how KDHE, KDADS, how does this CDF, how are all of these things related? I remember SRS. So we're hoping that we will give you a very clear understanding of these different departments, who you can talk to at each of these departments, as well as them giving us an update. We had the IDD modernization project, but we heard on Tuesday, and there were some questions about what we heard on Tuesday, and we were told, well, KDADS will answer those when they arrive. So we're looking forward to that as well. So Secretary Howard, would you come and address us, please? Welcome to committee.
Be here today to present an overview of KDADS, as you said, to the committee. And I will try to avoid using acronyms, which I just did. So I'll be talking to you about the Kansas Department for Aging and Disability Services, and just really trying to give, at this point, just an overview of what the agency is, who some of our key folks are, our key programs, and some of the top issues that may come before you. I know you have a full agenda today, so I'll try.
And Secretary Howard, if I may, also, we get emails, phone calls, people who would see us at the grocery store. I have this concern, so you might address, if you have any of these concerns that goes to this department, that would be helpful. Thank you.
Yes, absolutely. That sounds great. Thank you. So at the beginning of my presentation, I just have a very quick organizational chart for KDADS that shows some of our senior leadership staff. In the first line of it, you know, we have our deputy secretaries and some of the other folks like our chief counsel, and then I have our commissioners below that. I did want to do a couple of quick introductions. I did bring some individuals with me today. So I would want to first introduce Andy Brown, who is our Deputy Secretary for Programs. And as we talk through this, you know, Andy has oversight over aging programs, disability programs, long-term, you know, the Long-Term Sports and Services Commission, as well as behavioral health areas, and you'll see that in the presentation. I also have my other Deputy Secretary, Scott Bruner, over there in the second row, and Scott has responsibility over our state hospitals and our Survey and Certification Commission that does, you know, licensing and survey of nursing facilities and other entities in the state. Also, maybe relevant to your last question as well, I have Lee Keck here, and we actually have her picture and contact information on the next page. Lee is our Director of Governmental Affairs. She'll be on the ground in the State House a lot, but she's also a great person for you to contact when you get any kinds of constituent concerns. You know, you're welcome to reach out to anyone in the organization. If you have a state hospital issue, to reach out to Scott, or behavioral health issue, to reach out to Andy, but Lee's happy to kind of play that funnel, and we really try to be responsive as an agency, and I hope we have that reputation. And honestly, sometimes if things get asked to us that really are a different agency, I mean, we pass those along, and we let you know who that is and who that person is at that other agency. So let me just continue on with just maybe organizationally. On page 4 of our testimony, part of the responsibility of KDADS is the oversight of 4 state hospitals. And so we just wanted to give you a picture of those 4 state hospitals. We have 2 state psychiatric hospitals, Larned State Hospital in the western part of the state and Osawatomie State Hospital. And then we have 2 state hospitals for individuals with intellectual and developmental disabilities. Those are here at KNI and then at Parsons. You will hear later in the presentation, we are in the process of almost beginning to start construction on a new psychiatric hospital in South Central Kansas, and we're excited about that. But again, just an image of where those are. So KDADS has really 5 major program areas that I just want to give you just a little bit of familiarity with. We have an Aging Services Commission, a Behavioral Health Services Commission, our Long-Term Services and Support Commission, state hospitals, and survey certification and credentialing. And I'll just spend a little bit of time on each one of those, tell you what kinds of programs they're responsible for administering, both from the standpoint of some of those might be state programs, some of those might be programs we administer based on the federal government and federal funds and programs. So the first is the Aging Services Commission. And Dave Anderson is our Commissioner of Aging Services. But the Aging Services Commission is really about services and supports for Kansas seniors. Obviously, we're a graying nation and a graying state. A lot of issues and challenges. That includes community supports and some of the programmatic responsibilities related to the nursing facility program. You know, not the survey and certification, not the licensing, but some of the programmatic financing and quality pieces. This is the commission that interacts with your community agencies, the area agencies on aging, your nutrition programs, and then administers what comes from the federal government under the Older Americans Act. So a number of grants and programs related to key services that help seniors stay healthy in the community, whether that's nutrition services, whether those are other kinds of support services. The Commission also administers the Kansas Senior Care Act, which is a program that's been in place in Kansas for a number of years that provides some in-home supports for Kansas seniors who may not qualify under Medicaid for some services. Again, designed to really help seniors stay healthy in their community. And again, as I referenced, the Aging Services Commission also has some responsibilities around the nursing facility program related to rate structure, related to some of the programmatic regulations, and related to some quality activities. On the next page, just in terms of listed some priorities and accomplishments. Some of these I'll let you review on your own. I'll just mention a couple for each commission that I think are relevant. One area under Aging Services is the expansion of what's called the PACE program, the Program of All-Inclusive Care for the Elderly. And you were supportive of an initiative to expand the PACE program into Johnson County. And so we're excited about that. I think some of you may have been at a groundbreaking earlier this fall related to that expansion. We're also doing a lot of work related to dementia and Alzheimer's, part of that in collaboration with some work and grants that KDHE has received, and also we have our own Alzheimer's specialist on board right now. We're also in the middle of developing the latest 4-year state plan on aging, which is required by our federal partners. So our staff have been out and about over the last few months doing a number of listening sessions in communities and gathering input. And we also are trying to reconvene an advisory council on aging that had kind of been dormant for a few years and really trying to get some additional input there. So Aging Services is probably our smallest commission, even though we are the Department for Aging and Disability Services, but very significant as we think about the needs of our seniors. The second commission we have is the Behavioral Health Services Commission, sometimes called BHS. Drew Atkins is our commissioner. And the Behavioral Health Services Commission really supports programs related to mental health and substance use. And so within both of those, there are contracts with community agencies and partners to provide services to individuals and families who experience mental illness or substance use disorder. Through the mental health, many of you are familiar, of course, with your community mental health centers. Many of whom are converting now to what we're calling CCBHCs, or Certified Community Behavioral Health Clinics. And that's been a big expansion and modernization and expansion project in terms of services and financing that this legislature played a key leadership role in establishing to really enhance the availability of mental health services. In terms of some of the priorities and accomplishments, we've had the opportunity to really take a lead role in the rollout of 988 in Kansas. Deputy Secretary Brown leads the advisory committee that was established by statute. And Kansas has done a great job on 988. When you look across the country, you look at the statistics, we have a very high in-state answer rate where the calls are being answered in Kansas. They're not rolling to a national call center. We've been able to, expand the number of call centers in Kansas answering those calls, and we've been working very hard at, what happens after 988. So the expansion of the development of crisis services across communities in the state, an entire range of crisis services, as well as the ability to do mobile crisis intervention. So again, lots and lots of work there. We've been grateful for the dedicated funding that the legislature put within that bill that provides funding for those contact centers and for infrastructure around that. As I also mentioned, we also launched a successful 3-year effort to certify all 26 community mental health centers as certified community behavioral health clinics within the CARE program. I think 23 of the 26 have full certification as of this point. And that means that they've really had to expand the array of services that they provided. They have to have crisis services and a number of other pieces. And again, a really successful collaborative effort to make that work. We also have been, I think, very successful in seeking and receiving some competitive federal grants, particularly in the behavioral services arena. Through federal funding, we were able to award 10 grants to some federally qualified health centers and rural health centers for integration of primary and behavioral health care. And so we've been really excited about that project. So working a little bit outside of the community mental health system to say from the primary care side, how can we have better integration of physical health and mental health? We also, last year, this legislature moved the school's mental health intervention team program from the Department of Education to KDADS. And I think we've successfully onboarded that and expanded that as well. Part of the legislation last year expanded that to some private schools, and we've been able to successfully expand that. So again, lots of other priorities and accomplishments on behavioral health, but I think those are some of the most critical ones. So again, from the Aging and Disability Services as an agency, I've talked about the Aging Commission, the Behavioral Health Commission. The next commission is Long-Term Services and Support. This is certainly the largest in terms of funding in the agency. And I think one of the things I would say as I move into this piece is that while the Department of Health and Environment is the state agency for Medicaid, KDADS has a lot of Medicaid funding, and much of that evolves around the long-term services and supports program. So this program is around all of the state's efforts for community-based services for persons with disabilities. This includes administering what are called home and community-based service waivers. We also administer aging and disability resource centers and a project called administrative case management. Through this commission, we work really closely with community partners, the community developmental disability organizations with regard to individuals with intellectual and developmental disabilities, those providers of brain injury, home health agencies, and specialized medical service providers. I want to spend an extra minute or two just talking about home and community-based services waivers because, again, this is these are large programs. They can be confusing to folks in terms of what these are. Why do we call them HCBS waivers? But what these are Medicaid programs that are offered under the authority of a specific federal waiver. And what this federal waiver does is allow states to provide services that might not be provided typically under the state Medicaid plan. And these community-based service waivers, the HCBS waivers, those are all really about providing services to allow certain populations of individuals to be able to stay in the community who would otherwise need institutional care. So it may be a senior who, if they were not receiving certain in-home care services, if someone wasn't coming in and helping with personal care, they might be in a nursing home. It could be an individual with a child who needs technology assistance, who literally, without that specific technology, would literally grow up living in a hospital because they need the kind of equipment that is typically provided in a hospital. So we operate 7 of these home and community-based services waivers. We've listed those on slide 11. An autism waiver, the frail elderly waiver, again for seniors, the intellectual and developmental disability waiver, which is the largest, our physical disability waiver for individuals with physical disabilities who are under age 65, a serious emotional disturbance waiver for children with psychiatric issues, the technology-assisted waiver that I referenced that really is for a small number of children who really, without that technology, would be growing up in a hospital. And the brain injury waiver, which is a rehabilitation waiver. That's for individuals who suffer either a traumatic brain injury, say like a motorcycle accident, or an acquired brain injury like a stroke, and need rehabilitation after that to recover as much functioning as possible. So unlike the other waivers, brain injury is more of a rehabilitation waiver. It's more of a time-limited, shorter term waiver. The person may need other services afterwards, but again, that's what that is. And again, we could talk all day about HCBS waivers, but again, significant. Kansas was really a leader. Going back, 2 or 3 decades in the development of some of the early waivers around physical disabilities and IDD. Some of the priorities and accomplishments in this commission, one of the things that we're most excited about is that we're working on our application to CMS to develop a new community supports waiver. This would be a waiver for individuals with intellectual and developmental disabilities, but it would be for those who require less intensive supports than the current comprehensive waiver that we have. And it's really one of the approaches that the administration and the legislature has supported in order to address some of the waiting list issues we have. Because as we look at our waiver programs, particularly for the IDD waiver, we've had a very long waiting list. So families might put a child on the waiver when the child is very young and the child is turning 21 and they may still not be receiving services. We also have been very excited this year to be able to make offers to 500 Kansans for both the IDD and physical disability waivers to address those waiting lists based on resources this legislature provided last year. And we've made some great progress on those wait lists. All right, the State Hospital Commission, moving on to those under the authority of Deputy Secretary Bruner. As I said, we have those 4 state hospitals, so our commission provides that leadership guidance and oversight with regard to the state hospitals and making sure there's compliance with all of the requirements of both the Center for Medicaid and Medicare Services and the Joint Commission. We spend a lot of time, really working on stakeholder relationships within those communities, and also really trying to increase the services that might be provided in the community for individuals with intellectual disabilities or behavioral health needs. So again, I mentioned some of the priorities and accomplishments. We are excited about the work that's going on towards creation of the South Central Regional Hospital. It's important work. Again, we expect the groundbreaking to happen this winter. Another thing that I'm really proud of is that we have just brought on, this has been a multi-year project that we started early in this administration. Our state hospitals didn't have electronic health records. And so through some resources from the legislature and a long project over the last few months, we've been bringing those on. And actually this week, the last hospital, Larned State Hospital, is implementing the electronic health records. I mean, that'll be huge for lots of reasons. I mean, part of which is coordination of care with the community, part of which is just the quality of what goes on within those facilities. So we're very excited about that. That's been a huge programmatic and IT project to kind of just bring us into maybe a place where a lot of healthcare providers were a couple decades ago. So we're very excited about that. Another area of a lot of focus within the state hospitals has to do with competency evaluations. At Larned State Hospital, we have part of that hospital that is a forensic program. So we do work around assessing whether or not individuals who are charged with certain crimes are competent to stand trial. Individuals may be sent to Larned for that evaluation. And if they're found not competent, we also do that restoration work. There have been some long waiting lists, lots of pressures on jails and local partners. And so we've done a lot of work around being able to do more of that work in the community and doing community-based evaluation and restoration. And so we've been really excited about that work and those projects and those partnerships with mental health centers and jails. I also would say we've also been very thankful for some of the opportunity to increase some of our state hospital pay over the last few years. The legislature has really recognized some of the challenges with direct care staff in our 24/7 facilities and has given us some great flexibility there. The other thing I would mention, just in terms of talking about the state hospitals, when I said we had 2 psychiatric hospitals, for those who may not be aware, at Larned State Hospital, in addition to having a general psychiatric services unit and the forensic unit, we also administer the state's sexual predator treatment program. So we have, let's see, how many individuals there approximately, Scott, right now? So we have about 250 individuals who have been committed as sexual violent predators under the state civil commitment law that passed in the late 1990s that we provide treatment for. So again, just a different program than at our other facilities, but obviously a very large program with 250 individuals in that civil commitment program. All right, Survey, Certification, and Credentialing Commission. This is our commission that does inspection and licensing of a whole series of providers. You probably think about it most with regard to nursing facilities and similar facilities like assisted living and state-run, but they also do inspection and licensings of providers of disability and behavioral health services. This is where really our field staff come in. So we have kind of surveyors across the state that go out and do this work. And some of this work is under the rubric of the federal government in terms of the nursing facilities inspections that take place. In rare cases, we may assume temporary management of a nursing home pursuant to a court order. And I think some of you may be aware there was a point a couple years ago where we had 20 or 21 facilities in receivership, which we had successfully moved to new owners, and we don't have any in receivership at this moment, knock on wood. So some of the priorities and accomplishments. The Survey and Certification Commission really has to work really closely with some of the other parts of our agencies. So for example, when I mentioned earlier that we're working very hard with regard to 988 and our certified community behavioral health clinic implementation to expand crisis services, our survey and certification group then are working really closely for what does that mean in terms of licensure? How do those entities need to be licensed? What do those regulations need to look like? As I also said, we also completed the sale and conversion of nursing facilities that were in state receivership to new owners. We're also, we continue to work closely with all of our providers who are, continue to be challenged with workforce and some financial insolvency issues. We got some new responsibilities this year as well, where some responsibilities that had been at the insurance department for what are called, I don't know if that's even on here. Anyway, what that are called what? I know, I didn't want to use the acronym. I was going to say CCRCs, the Continuing Care Retirement Communities, those facilities that have a range of services. The responsibility for administration of that oversight was transferred from the insurance department to KDADS. We were also asked to begin registration of supplemental nursing service agencies and also to do some tracking of involuntary discharges that will be reported back. So again, lots of work going on there as well. KDADS is an agency that has a lot of partners, a lot of stakeholders, a lot of advocates, and so we do have a lot of stakeholder engagement. We do post-session updates with all of those stakeholders. We have budget input hearings, and we have regular meetings and receive input and recommendations from a number of groups, whether those are nursing facility stakeholders or the Governor's Behavioral Health Services Planning Council. That's kind of also under our rubric. Work with a lot of advisory groups. We also work very closely with the Department of Health and Environment. As I said, we're a large Medicaid agency, and I have been really appreciative of Secretary Stanik's leadership because I think she has really, she's created kind of a Medicaid governance piece that includes me and my team in a very close way. So we're part of those decisions really across two agencies for this around the state's Medicaid program. On page 18, we were given the opportunity to provide a lot of reports to the legislature. And so I've listed those. About 10 of those are statutory reports that we do every year, whether those are about our quality care improvement program or around the sexual predator program, some newer ones around 988. There also were a number that were added by budget proviso last year. So I think all but 3 or 4 of these have already been submitted and can also be found on the website. But we're more than happy to talk to any committee or provide more information to you as individuals if as you review those reports, if you need more information about those. I also just wanted to just briefly mention our legislative priorities this session. The first one, I mentioned that the mental health intervention team was transferred from that program, the school mental health program was transferred from education to KDADS. That was done by a very long budget proviso that was about 10 pages long in the budget bill. So we are going to be requesting that that program be codified in statute rather than continue to be a budget proviso. So we're excited about that. I think there was a lot of work done last year around, some consensus around what that might look like. We also need some statutory changes related to establishing the new South Central Regional Mental Health Hospital. And so we have a bill related to that. We also want to create a civil monetary penalty reinvestment fund. What we want to do here is we want to bring legislation where we would direct revenue that comes in from fines and penalties from some of our long-term care providers and put that into a dedicated fund instead of having it go directly to the general fund in order to benefit some of the licensed providers. So what this would allow us to do is, so providers of disability services and adult care homes, they would be able to apply for grants. Maybe they need a piece of major equipment. Maybe there's an infrastructure that's needed in that local facility. And so really be able to use some of those fines and penalties for the benefit of those programs. And again, we have some of that authority federally, and it's been a really, really valuable program. And I think sometimes we have some of these facilities that are kind of operating on a shoestring, and I think the ability for us to establish a program that would have some targeted ways for them to get some grants and resources to address issues that might be of concern in their facility. So again, we'll be bringing that to you. And then some additional legislation related to competency evaluation and outpatient competency. I indicated that we've been working, really hard on, having more of that happen in the community. And we're going to introduce some legislation that would make outpatient community-based treatment the first option or the default option. This is also part of a settlement agreement that we reached with the ACLU related to those wait times. And so one of the things that we agreed to do was to propose legislation that would make that the default option and also make sure that we receive copies of all the court orders for evaluation. So again, those are our 4 pieces of legislation. I'm sure there will be many more we'll have interest in the process. So I'll stop there. Senator, I know you have a lot on your plate today. I'll be happy to answer any questions.
We do. Committee, we have a very full agenda. However, I want to give you an opportunity here for a couple of minutes to ask any questions of Secretary Howard. Mike Thompson.
Thank you, Madam Chair. Thanks, Secretary. It seems like lately I've had a lot of people in constituents who need help with long-term care. They're having to spend down assets and they need the Medicare help, Medicaid help. What's the most efficient way for me to direct them to the proper services? Would it be through Lee or?
Yeah, and that would actually be through KDHE.
Oh, okay.
It just goes back to the
It's a huge
question, right?
Yeah.
Because it really goes back to sort of that eligibility piece. So
Okay.
Yeah, so I think through their liaison would be the first.
Okay.
So,
Okay. Very good. Thank you.
That would be great.
Thanks, Madam Chair.
Senator Holscher.
Thank you. My question is this: you mentioned after 988, and I'm curious to hear a little bit more about the future of crisis services. You mentioned mobile services. I know we've seen some counties where maybe law enforcement has started some different techniques. So does that partner with law enforcement or something different?
It can be a lot of different things. It can be a mobile crisis that comes out from a community mental health center. It can be, that we've had co-responder programs really for quite some time. It could be something like that. It's a wide array, and it can be everything from what that response is, that mobile response, or it could be a virtual response too, where things are even done through a tablet, things like that, right, where maybe the mental health professional isn't on site. But also in conjunction with that, also looking at what might respite centers look like, what might short-term crisis, where a person can actually go, as well. So it's a wide range. And again, under the CCBHC requirements, crisis services are required to be developed, but it could look different in different places. So, and right now, I think, we've been collecting sort of where we are right now, and we certainly have a number of parts of the state that have 24/7 mobile response. We have others that maybe have that kind of mobile response that goes out maybe right now only during, daytime hours, or maybe it's not on the weekend. But again, I expect to see continued growth, but we certainly want there to be, local conversations about what works best in that region or that community. Yeah, we're not trying to dictate the precise model,
Thank you,
And then how
Madam
things intersect,
Secretary.
for example, with the 911 call center, how 911 and 988 talk to each other, so.
Thank you, Madam Secretary. We have one more question for you, Senator Clifford.
First, I'd like to thank you. I have a constituent, Fragile X syndrome, 10 years on the waiting list. She was one of those 500 who came off. So
Fantastic.
very happy family. Two questions, if you indulge me, but I want quick answers. Compensated vows, are you paying the CCBHCs to do those so people don't sit in jail, or who's the local entity that does it?
Yes, the local entity are the CCBHCs, the community mental health centers, and yes, we are paying them to do that.
Thank you. Do we put guardrails on that conversion of community mental health centers so that other entities are not now trying to become CCBHCs?
There are other entities who would like to do that. Under legislative proviso, we cannot consider that until, I think it's like next year. There is some funding, there's some grant funding that you authorized that will go out next year that would begin to help other entities who wish to begin planning for that.
Just follow up, Madam Chair. So caution, we have an FQHC and a CCBHC. We only have so many people out in Western Kansas. They're just going to get in a bidding war for help. So I will be at the table, or the community mental CCBHCs. I think we need to see how that experiment works for a few years before we expand out. But thank you, Madam Secretary, very much.
Thank you, Madam Secretary. Committee, next we have an update on targeted case management with Michelle Hayden, Commissioner of Long-Term Services and Supports, who's under KDADS, Kansas Department of Aging and Disability Services.
Good morning. I'm Michelle Hayden. I'm the Long-Term Services and Supports Commissioner for KDADS, as I was just introduced. Happy to be here to talk about targeted case management, which is a pretty hot issue right now in our IDD services. In the LTSS Commission, we, as Secretary Howard said, we administer 7 different waiver programs, serving approximately 30,000 Kansans with disabilities and aging. So just to start out, to give you some idea about what targeted case management is, the definition is a state plan service designed to assist Medicaid-eligible members in gaining access to medical, social, educational, and other services. It is not a direct delivery of any referred service. It comes from the Social Security Act, 1915 G2, which allows states to define the populations of Medicaid members to receive the service and/or areas of the state where the service will be delivered. The Kansas Medicaid State Plan defines a population of Medicaid members that receive TCM. TCM is a statewide service identified for populations. Medicaid members do not have to be on the waiver to receive TCM. In a recent letter from CMS, it clarified that TCM is not an EPSDT service, which is early periodic diagnostic screening, diagnostic and treatment for children, and is available only to the populations listed in the state plan. So just an overview of the waiver in general. The IDD waiver was created in 1991, offers home and community-based services to individuals age 5 and older who have an intellectual and/or developmental disability. To qualify, individuals must meet the state's definition of IDD and require the level of care provided in an intermediate care facility for individuals with intellectual disabilities, or an ICF-IID, like KNI and Parsons. The IDD waiver aims to support people with IDD by helping them maintain their physical, mental, and emotional well-being, all while being enabled to live independently in their homes and stay connected in their communities. To be eligible for the IDD waiver, you must be 5 years old, have a diagnosis of an intellectual disability made by a licensed healthcare professional before the age of 18, or have a diagnosis of a developmental disability made by a licensed healthcare professional before the age of 22. Must also be determined eligible by the CDDO, or the Community Developmental Disability Organization, and meet the Medicaid long-term care threshold and be financially eligible as defined by Medicaid. So the waiver overview, these numbers vary just a little bit, but we serve over 9,000 individuals on the IDD waiver. We have approximately 4,552 people on the waiting list. And of that, the percentage of that received TCM and at least have one waiver service from the same agency is approximately 37%. So we'll get to the conflict of interest. When the organization helping someone to plan their care is also providing the services, it creates a conflict of interest. Even if it's not said out loud, it can be in subtle ways which guide someone to choose the services, even if those services aren't the best fit for the person. The pressure could be subtle. Things like suggesting someone stick with the services they're already receiving because it's easier, or not fully explaining other options. For example, if my case manager is from the same organization that provides my services, they might not emphasize other provider options. Instead, they could talk about how smooth things are going now, or how it's easier not to switch, even if it's services that might be better for me in the long term. So here are the risks that we have if we do not comply with the federal guidance. So from the settings rule requirements, the federal HCBS settings rule, 42 CFR 441.301, clearly states that there must be a separation between case management and service provision to prevent conflicts of interest. If we do not comply with this rule, we risk federal action to our waivers. So the intention of the rule, the settings rule, requires people to receiving services have full access to the community and real choices about their care without due influence from providers. Case managers must be focused solely on the waiver participants' need and not the provider's interest. So Kansas is currently on a corrective action plan. The conflict of interest is specifically called out on this corrective action plan. CMS has told the state that this cap will remain in place until the issue is resolved. So we also have another risk associated with this being in compliance with the federal regulation, and that is that we're currently working on the community support waiver, which aims to provide lighter touch services for Kansans eligible for IDD services. However, CMS has made it clear if Kansas does not have conflict-free case management in place, the new waiver will not be approved. Without approval, thousands of Kansans may miss out on the needed services that could help them live more independently. Our progress in improving the HCBS system would be impeded, leaving those on the wait list and in the current system without the reforms needed. So just before Christmas, December 16th, and following the special committee on targeted case management, Kansas received a letter from CMS reiterating expectations to resolve the current conflict of interest. The letter concludes, CMS strongly encourages Kansas to take these necessary steps in a timely manner to ensure compliance with the conflict of interest provisions outlined in the regulations. So CMS does not have to consider formal actions, which could include withholding federal reimbursement of impacted HCBS. These provisions represent an important beneficiary protection. So we've been doing a lot of work with stakeholders. So Kansas KDADS has utilized our ARPA funds to conduct a study to evaluate conflict of interest with TCM services, focusing on identifying and addressing issues which service planning and provision may overlap, and developing solutions to ensure compliance with the federal guidelines. Throughout the study, individuals and families, guardians, and providers participated in regular meetings to discuss key concerns and that share their experiences. From October 16th through the 17th, we convened a stakeholder group for conflict of interest to give advice to KDADS on providing grants to providers to make this, to resolve the conflict of interest with targeted case management. So key themes of that were the conflict of interest. Many voiced concerns about receiving both case management and services from the same agency, stressing the need for clearer separation. Consistency. Stakeholders highlighted the need for more consistent service provision across regions to ensure fairness and quality. Provider access. Rural areas face challenges with limited provider options, making compliance with separation of rules more difficult. So our final feedback, public town halls and surveys emphasize the need for phase changes, potential rule exceptions, and strong ongoing communication with stakeholders as changes are implemented. So we have a couple of compliance options. The first option would be to fully separate case management and service provision. This means agencies would either focus on case management or providing services, but not both. Full care, full separation removes any possibility of conflict of interest, ensuring the decisions about an individual's care are based solely on what's best for them. While this may require changes for some providers, KDADS is committed to supporting the transition with grant funding, technical assistance, and collaboration to make this process as smooth as possible. The second option is for providers who are unwilling or unable to separate fully. The second option would require introducing strict safeguards and oversight. Agencies could still provide both case management and services, but they would not be able to provide services and case management to the same person. This would prevent any conflicts of interest while allowing agencies to continue offering services within these limitations. The state must establish clear monitoring protocols to ensure compliance and support providers in meeting these requirements. This would be administratively cumbersome for both the providers and for KDADS. So the next steps, we've identified a policy roadmap. Previous slides outline a path to address conflict of interest with federal guidelines. This concludes ensuring separation between case management and service provision. We are committed to working with stakeholders through the Conflict of Interest Advisory Group. We are ensuring ongoing feedback for key stakeholders to guide the process. We'll have grant opportunities that we are working on now and will be made available to help agencies transition into compliance, offering financial support for separating case management from service provision. We continue to have open lines of communication with CMS to ensure we are aligning with the federal requirements and timely waiver approvals, preventing disruption of services. So transitions are never easy. People don't like change. The IDD system in Kansas has done a very good job of going through a lot of change through deinstitutionalization, managed care, and a global pandemic. So compared to this shift is quite straightforward. The resilience we have all demonstrates time and again gives us every reason to believe we can navigate the transitions successfully together. This is our moment to reinforce what HCBS should always be about, putting Kansans first. By eliminating conflicts of interest, we ensure that every person has the freedom to shape their own future with a voice guiding every step of the way. I can stand for questions.
Thank you very much, Commissioner. We have two other reports. Having served on the Targeted Case Management Committee, what we heard from stakeholders were that they like the fact that they can have services right there. And I'm sure that that's part of the conflict as well, is the convenience. And we'll talk more about this later. Committee, I urge you, if you have any questions about this, to reach out to the commissioner. We try to end committee at 25 after, as is our charge, because there's another meeting, a committee that comes in here, and they have to get set up, and most of us have to get to our 9:30 anyway. So we have about 4 minutes, so I guess about 2 minutes for each report. So, Arida, I hope you can talk really fast. By the way, this is about Bob Bethel. On off years, I have been vice chair of that committee. This year, it's the Senate's turn, so every other year we trade off, and I will be chairing the Bob Bethel committee this year. Go ahead, Irida.
Thank you. Given the time, I'm going to go straight to the recommendations that were made by the Bethel CBS and CanCare Oversight Committee. Those are found in the report on page 03. There are several recommendations that have been made. They recommended the KDHE implement the Graduate Medical Education Program for the Kansas Behavioral Health Center of Excellence with an 18-month timeline for implementation, that a budget proviso be drafted to address 3 pending issues pertaining to the Children's Health Insurance Program, or CHIP, and CHIP eligibility in current law is tied to the 250% of the 2008 federal poverty level, and federal regulatory changes regarding wait lists and lockout periods also need to be addressed. The Social Services Budget Committees are to review providing grant funding for local communities to apply for a grant to make digitally available a local resource guide based on the Explore Your Options Resource Guide, which is a senior resource guide that was created several years ago. A budget proviso be drafted providing for additional substance use disorder state funding through a grant fund to supplement federal funding for those SUD providers that have expended their allocated funds, the adoption of conferee rules for the committee, and then the program for all-inclusive care for the elderly. Medicaid rates continue to be rebased annually through a budget proviso. Several pieces of legislation were proposed. A committee bill to be introduced using the 2024 Omnibus Budget Proviso language regarding the funding for the Mental Health Intervention Team Program and keeping the program within KDADS. They also suggested legislation to support the Kansas Behavioral Health Center of Excellence and a change in the Home Plus definition from increasing the number of beds from 12 to 16 for both the standalone Home Plus facilities and adult care home wings that convert to separate but contiguous Home Plus facilities, and that the Department of Administration be required to adopt a written policy for negotiated procurement for managed care organizations to provide Medicaid services pursuant to a contract with the Kansas Program of Medical Assistance. The policy is to include a prohibition on the destruction of records that complies with the Kansas Open Records Act and other provisions. And these policies are to be made available to the public and potential bidders. And then finally, a rural emergency hospital be allowed to be granted a waiver from the physical environment requirement of a new facility for skilled nursing beds that need to be included for hospitals to be able to transition from a rural emergency hospital without having to meet the requirements of a new facility.
Well done, Irida. And finally, we have Elizabeth, who will give us our last, and it shouldn't be as long, on the Special Committee on Sedation Dentistry.
No, so the committee met for 1 day in October 2024. They heard from dentists, certified registered nurse anesthesists, a surgical center, private citizens, Interhab, Oral Health Kansas, and the Kansas Dental Association, as well as the Kansas Department of Health and Environment and an assistant revisor. The committee made 8 recommendations, and you can find those on page 03.
Very good. Thank you, Elizabeth. Committee, we are dismissed.